It's visible now?
Yes, sir. Visible, sir.
Okay. So it's a paravertebral space, is a wedge-shaped space, and it can first line itself. You can say it is extending craniocaudally and usually divided into thoracic paravertebral space and lumbar paravertebral space. Okay, that line you can include as the first line in your answer. And it is
Yes,
a
sir.
wedge-shaped space with the base facing the lateral sides of the bodies and the intervertebral foramina. And the apex continues with the intercostal spaces in the thoracic area. Lumbar I am describing separately little later, so you will know what is the extension of the apex at the lumbar space. So it is bound posteriorly by the superior costo-transverse ligament. This ligament is present only in the thoracic paravertebral area because there is no rib in the lumbar area. This will not be the landmark or the important anatomical structure, because once you pierce and go through this ligament, then only you get that pop feeling or the loss of resistance, which you will not get in lumbar blocks. So that is the main difference between these two. And it is anterolaterally bound by the vertebra and intervertebral foramina, and superiorly and inferiorly by the ribs. This is the thoracic vertebral space, and it is generally considered to end at L1. The thoracic vertebral space ends at L1, no defined cranial border. That means the drug can ascend to up to the cervical level also. Each segment of paravertebral space communicates superiorly and inferiorly over the rib head and neck. It is compartmentalized to anterior and posterior section by the endothoracic fascia. That is the reason why you cannot always rely on one single side block alone for this. Sometimes you have to give select 3 or 4 spaces and do multiple injections to achieve a adequate analgesia and block. But by giving a large volume, you can try to block multiple segments, but always it is safer to select and do multiple punctures and multiple blocks. So the space, what are the structures contained in that? That also you have to mention. They contain the branching spinal nerve, sympathetic nerve fibers, intercostal vessels embedded in the adipose tissue, and they usually continuous with the thoracic levels. And the orientation of the neurovascular bundle changes from medial to lateral in the paravertebral space, with the intercostal vessels and nerves arising anteromedially, but eventually lying directly beneath the rib between the internal and innermost intercostal muscles. So the spinal nerves, which are continuing as intercostal nerve, they will go beneath the ribs after they exit from the paravertebral space. So the thoracic paravertebral block is the technique of injecting local alongside the thoracic vertebra close to the where the spinal nerve emerges from the intervertebral foramen. This is the location where the nerves are blocked, and it produces a unilateral, segmental, somatic and sympathetic nerve block, which is effective for anesthesia in treating acute and chronic pain of unilateral origin of chest and abdomen. So if you want to do any bilateral procedures, you have to do the block on both the sides. That is also another important point that has to be mentioned. This paravertebral space extends on both sides of the spinous process. So you have to do bilateral blocks if you want to do an extensive procedure on the both sides of the chest wall. So this picture tells you this is the vertebra, this is the spinous process, this is the transverse process, this is the costo-transverse ligament, which arises from the transverse process and gets attached to the rib. And once you cut this and expose that, you can see the spinal nerves coming out through the intervertebral foramen and continues as the intercostal nerve here. And before that, it divides into the dorsal and ventral rami. And so the space actually is the green space here. This is the sympathetic ganglion, is also there. So our aim is to deposit the local anesthetic in this area and in this area. So if you want to do a bilateral block, you have to do both sides, inject the drugs. So it is preferable to perform thoracic paravertebral block with the patient in sitting position because the surface anatomy is better visualized and the patients are often more comfortable also for this. And when this is not practical or possible for some reason, then you can use the lateral or prone position also can be used. And the number and levels of injections are selected according to the desired spread of the local anesthetic. So you have to choose how many dermatomes or how many segments you want to block and do multiple injections depending upon that. And the surface landmarks are identified and marked with a skin marker before the block is planned. So this is I am describing mainly for the landmark based, anatomical landmark based block. So you can do that. And this is just to give you an idea how the transverse process and the spinous process are located, especially in the thoracic area. And this is how the markings are done. You mark all the spinous process in the center, and then 2.5 centimeters lateral to that, you mark the dotted line along that, and then every 2.5, this will be the point of entry and how the direction. So skin markings are made 2.5 centimeter lateral to the midline. That is that will be the point of entry. And these markings indicate the needle insertion site and lie over the transverse process. So when you go insert the needle into that, straight away it will go and hit the transverse process. The standard regional anesthesia tray with all the antiseptics and other preparation will be there, and you have to use the aseptic technique. Then you can use a 22 gauge 2G needle. If you want to do a continuous paravertebral block, you can ideally use a 32 gauge 2G needle, and better that the needle has markings on its shaft so that you know what is the depth that you will be inserting. Otherwise, there are depth guards to use. So this is the 2G needle that you can see. It has got markings, every 1 inch markings are there. All of you would be familiar with that. And this rubber thing is called the depth guard. So you can, once you hit the bone, this will be inserted into that. You fix it at that particular level so that every insertion you need not struggle. You can stop at this level and you will be able to hit the bone at that particular level. And an epidural set can be used for insertion of the catheter, or single injections also can be done. And requires proper pre-medication to ensure the patient acceptance and comfort during the block. And there are several different techniques of this thing, but classical techniques involve the eliciting of loss of resistance by piercing the costotransverse ligament. And the first skin and underlying tissue is infiltrated with lidocaine 1%, and the block needle is inserted again perpendicular to the skin in all planes to contact the transverse process of the vertebra. And due to acute angulation of the thoracic spine in the mid-thoracic region, the transverse process that you contact will be one vertebra lower than the one that you choose. So it will always be a little lower space. So you can see here the when you palpate this transverse process, this is spinous process. If you have marked this and then you enter the transverse process, you hit the transverse process of the lower vertebra, not the transverse process of the same vertebra. That was the small change in the anatomy of the thoracic vertebrae. The depth at which the transverse process is contacted varies between 3 to 4 centimeters. So having a marked needle, even if it is a single block needle, if it has got markings of 1 to 2 centimeters, I mean 1 centimeter gap at black and alternating normal color, then it be easy for you to stop, because the most important risk here is the piercing the pleura and producing a pneumothorax. So you have to avoid that. So by knowing the depth that you are going, it will be easy for you to reach the correct level and then stop at that without causing further damage. So the depth is deeper at the cervical and lumbar spine levels and shallower at the thoracic level. This is a practical point that you have to remember. And try to make contact with the transverse process before advancing the needle too deep or risking pleural puncture. So that is the important precaution that you have to take. And to minimize the complication, the block needle should be initially inserted only to a maximum depth of 4 centimeters at thoracic level and 5 centimeters at cervical and lumbar levels. And if the bone is not contacted, you are not in the correct space. You are between the two adjacent transverse process in the soft tissue. So redirect the needle and you can withdraw the needle up to the subcutaneous level and then reinsert either capillary direction or caudate direction and maintain the same 4 centimeter insertion depth until the bone is contacted. Don't insert it beyond that. When the bone is encountered, needle can be walked above or below. Always going below will be safer, and the transverse process will be gradually advanced until the loss of resistance is elicited by piercing the costotransverse ligament. So for a single injection, you can give 20 to 25 ml of local anesthetic, which you expect to spread gradially as well as caudally and produce multiple level blocks. But if you are planning to give multiple level injection, each injection should have only 4 to 5 ml of local anesthetic at the injected plane. Now coming to lumbar paravertebral space, this is limited anterolaterally by the psoas muscle. So there, the thoracic vertebra, we found it is the costotransverse ligament and the intercostal space, which are the landmarks, the boundaries. Whereas here in this, the psoas major muscle is there, and medially again the vertebral bodies and that is the same for all the levels, whether it is cervical, thoracic, or lumbar. The medial anatomy is vertebral bodies and intervertebral spaces, disc, etc. Whereas the lateral only will change, and posteriorly by the process and ligaments that are interposed between the adjoining transverse process. Here there is no costotransverse ligament. It is the ligaments intertransverse ligament. So there are ligaments here also which will give you the pop feeling when you pass through them. So unlike the thoracic paravertebral block, which contain adipose tissue, the lumbar paravertebral space is occupied mainly by the psoas major muscle itself. And the main bulk of psoas major originates from the anterolateral surfaces of the ventral bodies of the vertebra and originates from the anterior surface of the transverse process also. And these two parts between that arising from the body of the vertebra and those arising from the transverse process, just like your subclavian muscle having two heads and then forming a triangle, these two parts form from the psoas major, except near the vertebral bodies where the two parts are separated by a thin fascia within which lie the lumbar spinal nerve roots and the ascending lumbar veins. And the ventral rami of the lumbar spinal roots extend laterally into this intermuscular plane, not into the intercostal space as in thoracic vertebral space. Intermuscular plane formed by the two parts of the psoas major muscle, and they form the lumbar plexus there within the substance of the psoas major muscle. And when you do the lumbar paravertebral block, the local anesthetic is injected anterior to the transverse process into the triangular space between the two parts of the psoas major muscle, continuing with the lumbar spinal nerve root. So the lumbar paravertebral space communicates medially with the epidural space also. So this is the landmark, the markings that you do for the lumbar paravertebral space block. So the thoracic ends here, T10 ends here, then T11, T12. Then you mark all that. Again here also it is only 2.5 centimeters lateral to the midline. Okay, and then the needle direction, it can be straight and 90 degrees to all planes, or if you are able to palpate in thin persons the transverse process itself, you can direct or angulate it little ordered and then try to hit the transverse process. And